This is a deep cavity that we're going to be fixing in this video. Here's an x-ray of the tooth, and you can see that there's a deep lesion on the distal surface of the first molar. The tooth had a large existing Emax onlay, and the treatment of choice certainly would have been a crown, but since this was cost prohibitive for the patient, we made a plan to perform a direct restoration, and in this video we're going to go over that procedure. So here's the tooth clinically. You can see the dark area along the gum line and the Emax onlay. We're going to start by isolating the quadrant with a rubber dam from the second molar to the midline. And once we have good isolation, we're going to start our prep with a coarse grit KS1 burr on a high-speed handpiece, accessing the lesion from the occlusal aspect, and it doesn't take us long until we punch through. So we're going to continue our outline form with our KS1, and we're going to note that most of the lesion is limited to the lingual surface of the tooth, so we're going to open up that aspect a little bit more. And once we have good access, we're going to go in with our small carbide burr on a slow speed handpiece and begin excavating the soft tooth decay. Since this was a large lesion, it's going to take a few go-arounds of decay removal, inspection, and then decay removal inspection until we're back on hard tooth tissue. Still got a ways to go there. Gonna refine with a high speed and keep removing our tooth decay a little bit more on the lingual surface here. Mostly satisfied there. Gonna whack down a little bit more with a high speed, and then we're actually gonna add an occlusal dovetail into the Emax until we're down onto the dentin. Gonna finish that with a round burr. And then there's our prep pretty much good to go. Gonna be careful not to reduce too much close to the pulp because the tooth was still vital before we started working on it. Gonna round off any sharp unsupported enamel with a flame and then begin matrixing the tooth. Gonna place this sectional matrix as apically as possible and then stabilize it with our large plastic wedge. I like to apply apical pressure to the matrix band and wiggle the wedge in and out to allow the band to seat as deeply as possible. So here we're happy with the band, and we're gonna seat our separator ring. And similarly, I like to seat these as apically as possible and then give them a good shake to really force the teeth apart so we end up with a tight contact. And then we're going to burnish our band against the neighboring tooth with a ball burnisher thoroughly. And then we're pretty much going to be ready to restore. Going to use Equia Forte, etch the tooth for 5 seconds. Had an air bubble in the syringe there. Got a little messy. Gonna rinse it off thoroughly. Good 10 or 15 seconds of rinsing the tooth. Dry it off mostly, and there we're happy. We're going to apply our restorative material. I'm a huge fan of Equia Forte. Been using it a lot for about the last 2 years. This material came out about 4 years ago from GC, and it is indicated as a definitive load-bearing restorative material. Gonna overfill the cavity and pack it down with a moist cotton pellet. Wait about 4 minutes for it to set, and then disassemble our matrix. And I'm gonna remove the sectional band with some Howe pliers like I always do, and then begin reducing the excess restorative material with a large round diamond burr on a high-speed handpiece, and then refine our reduction with a carbide burr on a slow speed until we're back on the original margins. And there we're pretty much happy. Gonna remove the dam and check the bite. And we're pretty much good to go there. We're gonna apply our coating agent to seal up the material and light cure that. This patient knows that this is a hugely restored tooth, and a crown certainly would have been ideal, but you know, this restoration is going to stop the decay from getting into the pulp, and honestly I wouldn't be surprised if it lasted for many years. Check the contact with some floss, and we're pretty much satisfied there. Actually see a little bit of a lingual overhang that I'm going to let the patient know about. I usually send these videos to them. Appreciate watching them. So.